So the floor is open for question answer to Debanjan. Later I will come to some case-based discussion in the Indian scenario of the use of endoxifen. Any question, clarification, queries or doubts to Debanjan at this point? So we'll move ahead. Okay, Dr. Padma Kolikar. Please share the floor, Mike.
Good evening, everybody. That was an excellent presentation, Debanjan. You mentioned that in some patients where you didn't get adequate response, you switched over to 16 milligram. I'll just share my experience. I became a little over-enthusiastic after seeing the response to 8 mg, and in quite a few patients, I had switched over to 16 mg per day. And what I have noticed, about 7 to 8 patients, the patients experienced manic switch, and I had to decrease the dose. So this is something very interesting that I have noticed in my observation, in my practice. So I just wanted to share this with all of you. Because Debanjan, you haven't yet got the feedback from your patients whom you have titrated to 16 mg per day. So this is my observation.
Right, absolutely. So some of the cases we have also tried with the 16 milligram, Debanjan?
So few of my patients with 16 mg, they have received a response. Thank you for the feedback. But I just wanted to know, you said manic switch, right? So you prescribed 16 mg in individuals who already were having in depression, or how did it work?
Having a manic phase. Initially, when they were having a manic phase, I first started on 8 mg. And when I found that some residual symptoms were still there, then I switched over to 16 mg. Now the patient was stable for a few days, but then again I found again the manic switch was happening.
So in that case,
after a phase of stability.
Right. That's an interesting point actually, but in that case, I would not really consider it as a switch. Maybe I would consider the same episode which came back. So that could have even been, let's say, the natural process of the disease, because if it comes back within 12 weeks, we'll consider it to be the same episode, neither recurrence nor relapse. But it's interesting to note that maybe if we increase the dose to 16, does the anti-manic or anti-impulsive effect get reversed, or does it get altered? That would be a question.
I was really concerned about. And what you said, if we don't call it a manic switch also, but the patient remaining stable for a substantial period of time, and then again the manic symptoms coming back, maybe after a period of say 6 weeks, then definitely I think it's something we should be concerned about. Okay, and this happened not only in one case, about 7 to 8 cases I noticed this phenomena.
Right.
Thank you.
Thank you, Debanjan, for excellent presentation. I have an experience mostly when I started prescribing endoxifen. In fact, I was also included in the study as Ranjan was there. Initially, I used it along with the other mood stabilizer, like either lithium or divalproate, along with this. Initially started when one mood stabilizer is not enough, I added this endoxifen, and definitely it worked very good, and that is why I started sometimes as a single mood stabilizer along with antipsychotic at the initial stages, and then taper off and off. Maybe some few days for benzodiazepines also. And not only that, as you mentioned, it is as our doc, it is not an disorder specific, rather impulsivity. In fact, right now I am doing practice in borderline personality disorder. I am prescribing only this endoxifen. Very recently, I mean last 6 months, I'm not giving any antipsychotic or other mood stabilizer, not lamotrigine, even lithium or like this, only endoxifen. And I have changed my style of practice regarding this, and it was amazing, my experience. In fact, I heard it in Sri Lanka when I think someone presenting endoxifen in bipolar disorder. And it was really good, and I think you can try. especially in fact in substance use disorder, there are lots of time they are presenting with bipolar disorder as well. The presenting symptom is substance use disorder. In those cases also this molecule is very effective. Thank you.
Yes, please. Next question.
Thank you, Dr. Debanjan, for your excellent and enlightening presentation. I am Dr. Monish Rai, a consultant neuropsychiatrist at the Mission Hospital, Durgapur. I have used this extensively in my patients in all the domain, like you have said already, RDoc, like I use it as a trait-specific medicine, like in, as Sarah has already mentioned, like in emotionally unstable personality disorder, suicidal patients, and also manic patient. But what I have found in two of my patients, in female patient, I would rather like to give certain emphasis on this, because as we all theorize that it does not have any reproductive side effect, but I have found hyperprolactinemia in two of my patients. Whether I don't know, because there is no other antipsychotic which can be attributed for this hyperprolactinemia, but I have found this. They have got this, they have got amenorrhea, and when I checked it out, and it was a hyperprolactinemia, and I also ordered for an MRI brain, and there was no such pituitary adenoma was found. So I want to share it with you.
How it is possible, Debanjan, can you explain? Because it doesn't involve the tubular pathway. It is a novel mechanism of action, direct PKC inhibition. How that is possible?
Yeah, thank you, Gautamda, and thank you, Dr. Manish, for sharing the insights. First, with regards to what Gautamda said, I think the impulsivity domain or the impulse discontrol is quite significant in the cluster B personality. Some individuals, not all, can't generalize. But in them, we all know that there is no FDA approved medication, and it's always a symptom targeted pharmacological with psychosocial management. So if we can plan monotherapy with endoxifen, I think that's a good idea. Of course, if sleep and agitation is too much, you can use a low dose antipsychotic along with that. With regards to what Dr. Manish said, I think it's a very interesting finding. I had actually another experience. One of my patients developed, without any other background reason, she had amenorrhea and then started having menstrual irregularities. The person was only on endoxifen, nothing else. She didn't have any past history. So I actually kind of had a chat with some of the colleagues working on the molecule and also search literature. In fact, the phase 3 trial which I presented, even though non-significant, rare side effects reported were 3. One is menstrual irregularities, one is hyperprolactinemia, which can again lead to clinical or non-clinical manifestation. The other thing is in a male, which was psychosexual concerns, which was erectile dysfunction. The problem is because they were non-significant, the study didn't, or the trials didn't comment on them. But if you look at tamoxifen, if you look at the ER1, ER2, the estrogenic receptors, there is a certain propensity of any molecule of congener of tamoxifen to work in the same lines, and it can work on the receptors present in the breast, on the ovary, the uterine linings, and similarly in the CNS pathway. The only flip side is what they claim, that the affinity towards estrogenic receptors is nearly 10,000 times lesser for endoxifen compared to tamoxifen. So theoretically it is possible. We all know that every individual's genetic makeup is different, their receptor profiling is different. So unless we really go for a complete receptor and cytogenetic profiling, there may be a few cases with side effects such as this. So in ladies who are in the peripartum period, or who are lactating, or in pregnancy, or individuals who have PCOD and may have already existing gynecological abnormalities, I would probably be on a bit safer side with endoxifen.
Thank you so much for this valuable insight. Dr. Tirthankar Dasgupta.
John, now I have one question to ask you. How far you are comfortable in using endoxifen as a monotherapy? Because in my own personal experience, I found in subset of patients, it works wonder, even as a monotherapy. And 2 of my patient is continuing for this molecule for past 1.5, almost 2 years, maintenance. So how is your personal experience so far as monotherapy is concerned? Why increase the pill burden as well as cost burden and everything if PKC inhibitor direct can work?
Thank you, Tirthuda, for that. I think it's a question which probably is something we all need to ponder about, with relate to this molecule. If the whole USP is its ability as monotherapy. In fact, the FDA approval is for bipolar mania, for single episode mania, and for mania with substance use. One of the flip side, as I was mentioning, is that endoxifen has a potential to disturb sleep and can cause paradoxical excitement and activation at night time. The diurnal rhythm that is disturbed in mood disorders sometimes may need an additional temporary antipsychotic or benzodiazepine to deal with that part. I would not add